Welcome. I'm Clara McKay. I'm CEO of the World Ovarian Cancer Coalition, and I'm delighted to be chairing this panel on cancer registries. So I'm really delighted to introduce our small panel of cancer registry experts. We have Isabel Soya Mataram, who is from the International Agency on Cancer Research. And from the African Cancer Registry Network, we have Dr. Max Parkin and Bing Liu, both who have very kind of interesting and hands-on experience of working on a cancer registry from scratch. So Max, I think I'm going to start with you because you have a very long and distinguished career in cancer registry work. And I really just kind of want to start with a basic question about why cancer registries are so important. In particular, why are population-based cancer registries important?
I mean, they're one of the major sources of information we have on cancer in communities. The population-based registry you mentioned is there to collect data on all the cases of cancer occurring in a community, in a population. That's the cancer cases, whether they treated in hospital, whether they get proper treatment or not. So it's capturing information on everybody. And for that reason, it's a tool that's useful for, let's say, epidemiology and public health purposes, rather than just the management of a hospital or auditing a hospital's workload. I think this is a little summary of what population-based cancer registries are doing. As I said, it's a public health tool, so it's describing the size of a particular cancer burden, that all cancers or a specific cancer, and the types of cancer that are occurring. And for that reason, it's there to help us define what are the main priorities in public health and cancer care in particular. And then, of course, if we're intervening to try and diminish the number of cases or improve outcomes, the cancer registry is there as a monitoring tool to tell us how effective our cancer control activities. So that's why it's a key element. Essentially, for disease surveillance, we have two broad approaches. One is through death certification. That's telling us how many people are dying from a disease. It's a very important metric, of course, but it's only capturing one aspect. It doesn't tell us how many cases there are, what happens to them, how many people don't die, what stage they're coming out, what sort of treatment they're receiving, and so on. And that's where a cancer registry is particularly useful.
Thank you. And we're going to ask Ian to share a presentation on your work on the African Cancer Registry Network. But just before then, it must be very challenging, I would imagine, and I'm interested in how you convey the value of cancer registries to particularly low resource countries where many other health priorities may be competing. This feels perhaps like a luxury. How do you express the value and importance of that in those settings?
Again, this goes back to from looking at those uses of the registry I showed you. Of course, it's very valuable to researchers and so on who are doing epidemiological research on cancer. But I think more than that, it's a tool for planning cancer control activities. We go back to Isabel's parent organization, that's the World Health Organization. It set out a lot of guidelines about how you should plan cancer control activities. It seems self-evident, but you need to stress to ministries of health around the world that if you're going to set up a program to plan for dealing with cancer, you need some intelligence mechanism behind it. You need to be able to document what's the size of the problem, what are the priorities, how might you approach it, and how successful you are. So this is clearly written into these guidelines that you need a cancer registry to do that. This has all been recognized by World Health Organization itself. This is an assembly resolution that was passed some years ago, saying that all countries should have in place a mechanism for monitoring cancer and evaluating their cancer control programs, and so they should have in place a cancer registry. This is an old one. This has been reiterated since. So it's a well-recognized necessity for government. So theoretically, all ministers of health put their name to this. So to try and convince a country, say, now you already said this, so you should realize that this is a really important tool if you're going to approach cancer in a rational fashion.
Excellent. Thank you. So that's kind of the why, and why it's important, and why every country should participate. So I know you again are very much hands-on and on the ground with the African Cancer Registry Network project, and so I think you're going to share with us a little a presentation that shows kind of how you're approaching it within Africa. So it's a more kind of on the ground insight into setting up a cancer registry network. So if I could hand that over to you and you could take us through the presentation.
Right. Thank you, Claire. Thank you for giving us the time to present the work done by the African Cancer Registry Network. So our journey started 11 years ago when our parent organization, the International Network for Cancer Treatment and Research, decided to give some support to some of our registries in Uganda and Kenya. So back then, only 2 members. Then later on, some of members brought in support from the Doris Duke Foundation, which is based in the US. Then we expanded to 7 members. And as the work goes on, GSK oncologists at that time still exist. They decided to give us quite a big grant for 2 years. And with that source of money, we were finally able to formally establish as a consortium. We expanded our membership to 21 members. So the coordination centers really consisted of just Dr. Parking and myself, and we are based in Oxford University, and we carry on as the coordination center, and we work very closely with our members on the ground in the continent. And throughout the years, we had a lot of support from various international foundations, organizations, or research bodies. And these are just some of the major partners we work with over the years. Quite a number of them are not shown on this slide. And as today, as I'm speaking now, we have 35 members in 25 countries. That includes English-speaking, French-speaking, and Portuguese-speaking countries. Of course, our main goal is one day, and hopefully soon, we will be able to cover all countries in the sub-Saharan Africa. And being a consortium, we do have some criteria for our members. Many, as you can see, and 2 of them are most important. One of them is these registries must be population-based and achieving at least 50% coverage of the target population. And after joining the network, within 3 years, they should improve the coverage to over 70%. And the second important criteria is all our members must contribute their data to our network database annually. And why is that important? And later on in the talk, I will tell you why. On this map, you will be able to see all the members dotted on the map. We are seeking support to start something in Cameroon, Gabon, and Angola as well. So hopefully in the coming 2 years, we will have new members appear in the central part. As a network and as a research body and organization, we have our overall goal. So our overall goal would be to increase availability of information on cancer incidence, stage, and survival. And to do that, we have 2 parallel strategies. One is to increase the number of countries which have population-based registries, and the other one is to improve the quality of data coming out from these registries. So it's quantity and quality at the same time. We do our work together with the International Agency for Research on Cancer under the scheme called the Global Initiative for Cancer Registry Development, which they initiated a couple of years ago together with the UICC, Union for International Cancer Control. And we act as a regional hub within this scheme. And being a regional hub, we have 4 main functions. This is for training in the past few years when activities were still can go normally before COVID time. You can see that in 2017, we have a list of countries visited, 18 as well. Whenever possible, we would like to visit new sites where they have the enthusiasm to start a new registries. So we would go and visit them and tell them what is needed and how to go about it with very limited resources. And occasionally we will visit existing members to review the current conditions and try to help them to improve it or even extend within the same country. These are some examples on training. You can see the pictures with lots of people. Those are the workshops or training courses where there's a large audience and the topics are uniform and basic. Then picture with smaller numbers. Those are workshops. For example, the one in the middle with the arrow pointing towards the left. That was one of the mentorship hosts in Nairobi. So we invited 5 registry managers coming from 5 different countries to learn how to manage registries in their countries. Our German colleagues managed to secure a grant from the Volkswagen Foundation to support a large scientific workshop in Entebbe in 2018. And the topic was focused on cancer epidemiologies and infectious disease in Africa. So we engage all the medical professionals from within the network, as well as some international experts who are either experts in epidemiology or in infectious disease. We came together, we presented our data, and then we started discussions on topics which related and interest us all. The workshop lasted 4 days, and it was very beneficial to all, and we had a quite number of publications following the workshop. The last but not least is the research and publication. So when we generated the data, we want them to be seen. So we try to present our data either in conference as a poster or talk, or mainly as publications in journals. But as coordination center ourselves, also prepare guidelines and manuals to help our members to improve their work and to help them to carry on day-to-day exercise. The examples you can see is the light blue one on the right top corner. That is a childhood cancer staging manual for our registries in Africa. Why is it different from the Toronto staging manual? Because the healthcare system is quite different in Africa, and data stage information of stage is not always available on medical records or from the doctors. Our registrars have to learn to assign a stage to the cases they find and how to do that. So that's why we prepare these menus, so our registrars are able to assign stage. And the similar purposes for on this essential TNM flow chart in the middle, you can see. These are for adult cancers, but the purpose is the same. We hope that our registrar would be able to assign stage on the cases they recorded based on the information coming from the medical record. They are specified for our registrars because, as I mentioned before, the way the information presented in Africa is quite different from the developed world. They are often handwritten and the information is not clearly explained. This is very much needed, and we saw the improvement after a few years of training and supervisions. These essential TNM flowcharts are all included in the standard procedure manuals, which is on the bottom green copy. And all our member registries have a copy of these menus, and some even tailored the menu to their own use, which is a way forward in the future for all the other registries. And in general, our network database is used for many international projects, such as Global Can. And our current submission is being used for the Global Can 2020, and that should be available very soon. And for members for the data who are not quite good enough for the international publications, we try to collect them and publish them within our own publications. Those are the 3 booklets you can see on the screen right-hand side bottom. The activities of this year. At the beginning, we thought because of the lockdown, we might be quite quiet and got nothing much to do. But it turns out we do have a lot of activities, especially on training. We've realized we finally got the time and energy to catch up on training. So together with Bloomberg, we started translating all our teaching materials into videos. And locally, we were able to get some funding from Bristol Mayor Foundations to develop a local course within Kenya, and some of the students are also coming from other countries in Africa. The course was most focused on basic knowledge of cancer registration methods and principles. Although the students didn't have much background knowledge, they were somehow very much engaged, and they learned a lot and show a lot of enthusiasm in the course. There are other ongoing activities. As a network, what we can afford to the rest of the world, to researchers, policymakers, these are the few items: patterns of cancers, change of burden, affected population, available treatment, patient's choice, treatment outcomes. Of course, these informations are not always immediately available from our database, but all these informations are possible to be generated by our registries if resources is available. And for ovarian, I would like to point out that so far there is no extent review for ovarian cancer in the continent. The reason for that is there's not much data available. And also we haven't been able to identify any suitable African young researchers who will have the sufficient knowledge to take up the topic and look into the subject. But we are working on it, and hopefully we will reach there soon. And if there's any donors or foundations listening to this talk, your support would be very welcome for the following proposals. We could randomize some samples across the whole sub-Saharan Africa from our registries, and we can try to obtain vital status, try to abstract information on stage at diagnose. And if resources is sufficient, we can even look into the treatment information. This would be very important. All this information would be very important for policy makings and healthcare planning for the country as well as for local hospital. This essential staging flowchart is newly available, coming from UICC and IARC. We haven't tested it, so it would be really useful to ask our registrars to stage some of the cases, and then we ask the doctor to stage the same cases, and then we compare the results. And from comparison, we can see that what extra training is needed to enable our registrars to be able to perform a more correct staging practice. Thank you for your time, and that's all from me.
Thanks so much, Bing. That was really helpful. So Isabel, I'm going to turn to you now. I understand in your work with the International Agency on Cancer Research that you're doing some work around ovarian cancer staging, which is obviously very of interest, great interest to us. So I wonder if you could take a few minutes to share that work with us.
So thank you, Clara. I am indeed an advocate for data, and then I work a lot using that data, but also then trying to improve that data availability. And then I think it's so important, as Max has mentioned and Bing has mentioned this as well, the usefulness of data to inform action and monitoring the progress, and also adapt the actions or cancer control program wherever it's needed. So stage is really important because it's an important indicator of survival. But then if you have that stage data, you then have the insights or the knowledge to say something about cancer awareness in the population. But you can also then see early detection, whether then cancer are detected earlier or later. For some cancer sites, it's important to inform screening program, for example, but also then on the management of cancer itself. And then if you have it at the population level, like Max said it, then you know all this information for a whole region, for a country even sometimes, that is then really representing that population. And then from the experience that now that I'm collecting this data, it requires an iterative process. I mean, you see that the time that's taken for the network to evolve, it's similar actually if you see it then also in collecting the data and improving the data. So in the projects that we are doing, We had then first, for example, then to develop a protocol for which then that data, how the data should be defined and how it can be collected. And we're doing this together with Max, together then with the registries themselves, but also involving clinicians. So then the data that are collected make sense or then useful also for the different stakeholders. And only until we agree with such protocol, which later on fits on a lot into guidelines or standards, we then start the data collection itself. And when the data collection happens or finished, we first looked into then the data that is produced, the results, before then we start using it. And often we actually come back again to the registry, so then the registry can improve that data, so then it really then can be comparable over time for the registry themselves, but also then across populations. It does take time, it is iterative, but then I think with the collaboration with networks, as then exampled by then the African Cancer Registry Network, I think what we have seen actually really improvement in the availability of data, so staging data, survival data, cancer data, good cancer data has become more and more available. And then more and more reusable as well. And then you see that people are becoming more and more interested in it. And we are starting it not only for research, but then also then for a lot of different stakeholders, which I think is really interesting and exciting at the moment.
I would agree, absolutely. So when do you have a sense of when the ovarian cancer staging data might be released or available? Or
hopefully soon. We have all the data assessment done, and then we have received it. We work a lot with Max and Being, and then they are waiting for that as well. It's probably from our part that's a bit slower, but it's coming really soon. We're writing then kind of the global overall paper, and then after that we'll release then ovarian cancer specific results.
Brilliant. That's really interesting. And then just one last question. I understand there were two kind of programs that maybe fit together or overlap, the SERVMark and the SERVCAN. Can you say a little bit about those two?
So for the survival project that we're doing then in the section, not alone, of course, with a lot of different people in different parts of the world, there's two programs or a line of work. One is then SERVMark, where we're looking mainly in high income countries where then there is access to healthcare. The idea is then to compare survival, knowing that everybody has access to healthcare. So the countries were then selected based on that. And then there's another project where then we are working more with low and middle income countries, having then for each of the region a benchmark country for which then we are going to use to compare then data and results for that region. And then in that work, we're then also working much more in terms of trying then to improve the data availability, the capacity of the locals to collect such data, so this can be done then repeated in the future, but also in analyzing and using such data, so then everybody then can use that data then for whatever reasons mentioned before as well, to improve survival, etc., in their own local situation.
Thank you. So now I want to kind of we're coming up to the end, but I wanted to bring everyone back in. So if you want to put your video and your audio back on, and just kind of probably a bit of a question to everyone. And I guess we've talked a bit or quite a bit in this conversation about the power of cancer registry data and what we can do with it, and then look very specifically at a very innovative and inspiring project with the African Cancer Registry Network. So, but we also know that actually probably where the least amount of data is available is in low resource settings, and possibly the most urgent need for data is in low resource settings. So I'd be interested in reflections on that. How do we put more focus on that, and what are the ways that we might be able, I think, particularly from a patient advocacy perspective, influence moving that up the agenda in terms of priority? And is the answer to start small and work up a bit like the model that being shared with us earlier? So Max, I'll start with you on that question.
Well, Claire, obviously we think so. Yes, you're absolutely right. The biggest need is in lower income countries, because the the data is really poor and sometimes non-existent. I mean, how can you interest other people? It's difficult because, of course, you know, ovarian cancer is a problem everywhere, and so to tell patients or survivors that, oh, this is an issue in low-income countries, an issue for them as well, of course. So it's difficult to think of others a long way away when you've got a problem of your own. But I think the reason we concentrate on these low and middle income countries is that's where a small amount of effort and funding, working with IARC, International Agency for Research on Cancer, it sounds very grandiose, but they're a very small organization with only very limited resources, as a matter of fact. So trying to have the maximum impact for a small resources is the goal, and that's why we've tended to concentrate on these countries. And yeah, I mean, that's why the network has been so important. It really does, it's a sort of reinforcing mechanism to try to multiply what some people in these countries are managing to do to share their experience with others. So we've only got a small input. It's a sort of local reinforcement mechanism. There's a lot to do. And as I said, when we first had our interview, nobody paid very much attention to ovarian cancer because it's never been thought of as a priority cancer. We spent a lot of time on cervix and breast, a lot of time, because these are very, the focus of a lot of interest. And in men now, there's been a lot of interest in lung cancer and prostate cancer and so on. But there are some important cancers that tend to get pushed off. But in women, I think it's ovarian cancer. And in men, bladder cancer, it's an important cancer which we pay practically no attention to because it's difficult to manage, difficult to screen, difficult to do much for. And same for ovarian cancer, you know it well. It's difficult to diagnose early, difficult to treat. And so, you know, what can we do to, oh, let's concentrate on something that's easier. Cervix and breast, they're big problems, and we know how to tackle them.
Isabel, is that your experience or your view, perspective in terms of global cancer registry data? Is it better for some cancers like breast than other cancers that are more challenging? And to Mac's point, what are the, what key levers? Is it funding? Is it profile that we need to actually start to have greater equity and coverage in terms of vital cancer data information?
Yeah. But all what Max mentioned is, of course it's true for low and middle income countries where the data is bigger and actually where you can really make a big change. I think resources that we have put in, if you think about it, in such countries can go a really long way. Then I think it can be used also then to reiterate, look, we can do this for this cancer, we can do this for another cancer, etc., etc. Patients can really advocate for the use of the data, demand for the use of the data in terms of, deciding their clinical decisions and so on. Demand that the data is being used and produced. There's a lot of discussion at the moment where then data becomes more difficult to get because of whatever reason, security and so on. But if you see what has been happening with Cancer Registry, I don't know whether, Max, you've been longer in this area, but I think patients can really do a lot, and patient has become a strong, important group. And I think you need to demand that the data is made available, demand that the data is then used for research or for decision making, and that's already then going to help a lot.
Thank you, and I think that's such a good point, and I think actually it's well made, in some of the other contributions to this Better Data, Better Outcomes event are really exactly about that, about how patient advocacy organizations can use data and use it as a lever and show the value and how it can drive change. So Bing, do you have any last thoughts about how we can bolster the efforts to develop cancer registries from your experience?
Yeah, so in some of our follow-up programs, our registrars will be phoning patients to find out what type of treatments they get, and if they abandon it, why, and why there's such a huge delay in diagnosis between the first symptoms to the diagnosis. And so I can understand some patients don't want to talk about it. It's sensitive, it's difficult, and have to deal with the cancer already. But it would be really helpful if the patients understand that this information is not only just a story, but in terms of later on planning and helping to improve the healthcare system is really crucial. So if they can open it up and just let our registrars to collect those information, then I think, yes, that's really, they can contribute to it so much without seeing it themselves, but in the long run.
Thank you. Thank you. I think that's such a brilliant point, that it's not just about your individual experience or story, but it's part of a bigger kind of narrative, as it were, about what's happening, nationally or globally. So I think with that, I think we've come to an end of our time. So I really just wanted to thank you all for joining us today, for sharing your insights and your experience, and some really very interesting and I think really important points that you raised with us. So on behalf of the World Ovarian Cancer Coalition and all of our 160 patient advocacy members around the world, thank you very much. It's a really helpful, very helpful discussion.